Hello, everyone. Let's go ahead and cover Chapter 11, Diseases and Conditions of the Urinary System. First we have is orderly function of the urinary system. So if you remember back in anatomy and physiology or medical terminology, what the urinary system does. So it produces, stores, and excretes urine. The kidneys facilitate reabsorption of necessary nutrients, water, and electrolytes, and then also clean the blood of waste products. So the kidneys are basically the sanitation workers. They clean out the blood and get rid of all the waste. The kidneys also regulate water, salts, acids in the body, and fluids to ensure homeostasis. And so acid-base balance is also controlled by the urinary system as well. Then we have the structures. So the urinary system consists of two kidneys, two ureters, a urinary bladder, which is one, and one urethra. So two kidneys, and they sit under the diaphragm. And the ureters connect the kidneys to the bladder. And then the urethra is the exit from the bladder to the outside world. Women have a very short urethra. That's why women are more prone to urinary tract infections, whereas men have a longer urethra because the urethra in men is both urinary and reproductive. So here's our structures. On top of the kidneys, you have the adrenal glands, which is part of the endocrine system. So those are actually separate organs. And then we have the kidneys. The right kidney sits a little lower because the liver is here. The ureters are here connecting, and then these are where the ureters attach. So this is where the part of the bladder is sliced away. And so the ureters attach very low on the posterior aspect of the bladder. And so the kidneys process blood to form urine that contains waste products to be eliminated from the body. So the three regions of the kidneys, we have the cortex, the medulla, and the renal pelvis. So we have all the filtering, and then the renal pelvis is where the urine collects and then goes down through the ureters. So blood enters the kidneys by way of the renal artery and leaves through the renal veins after all the filtering. So here are the structures here, the renal capsule, the calyces, the renal medulla, the cortex. The cortex, you want to think crust. Medulla is the middle, and here's the renal pelvis, which is the collection area. And then we leave via the ureter. The renal artery is where blood comes in, filters, 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 and then exits via the renal vein, nice and cleaned out. All right, nephrons, the functional unit of the kidney. So each kidney is composed of about 1 million nephrons. So urine is transported from the nephron to the renal pelvis and then to the ureters. Once urine collects in the renal pelvis, there is no change from what leaves the renal pelvis to what exits the body. So the components of urine, the concentration of urine, nothing changes. So the nephron is composed of a glomerulus, Bowman's capsule, the proximal convoluted tubule, the loop of Henle, the distal convoluted tubule, and then the collecting ducts. So again, these structures should sound familiar to you from medical terminology or anatomy and physiology. Here's structure of the nephron. So here we have, this is a collection of capillaries, and capillaries are one cell thick, so it's easy for exchange. This is the arterial side, here is the venous side, and then here are all of the structures. So we have the glomerulus and then Bowman's capsule, which is around it. All right, urine formation. We have the three processes: filtration, reabsorption, and secretion. So filtration, reabsorption, secretion, those are the three processes of urine formation. So this is just showing you here what's happening in each level during urine formation in the nephron. Disturbances in renal function. Infection can cause disturbances, scarring, toxic necrosis, trauma to the urinary tract. That can be internal and external trauma, causes cause of urea to accumulate in blood, and urea is a waste product. Congenital or acquired structural defects and tumors cause obstructive diseases. Symptoms of urinary disease: nausea, loss of appetite, or anorexia, fever, headache and body aches, flank or low back pain, edema, so swelling, decreased urinary output, or scant urinary output, which we call oliguria, hypertension, and pruritus, which is itching. Acute glomerular nephritis. So we can see from this word we have inflammation of the glomerulus. It can be primary disease of the kidneys or develop due to systemic disease. Acute glomerular nephritis is marked by proteinuria, so we have protein in the urine, edema, so swelling, and decreased urine volume. Usually follows a streptococcal infection, so group A beta hemolytic streptococcal infection. It can be idiopathic or it may result from an immune reaction which traps antibodies. In some cases, the antigen is endogenous as an accompaniment of tumors. So changes occurring in the nephron here. So here's a normal glomerulus. Capillaries open, the blood is flowing. Here we have mild glomerular nephritis. So we have inflammation and immune complex deposits. And now we have narrow capillary lumen, and now we have red blood cells and proteins which leak. Red blood cells and proteins are large and they should not be leaking through. Severe glomerular nephritis, now we have a lot of inflammation, little blood flow, so now we have oliguria, so scanty urine output. Acute glomerular nephritis continued. Treatment, antibiotics for the infection because we're treating streptococcal infection, diuretics to control edema and hypertension. Sodium intake is restricted. Corticosteroids are used if immune reaction is what's suspected as the cause or etiology. Prevention depends on the cause of the condition. So if it's infectious or autoimmune, pregnant women with a history of acute glomerular nephritis require frequent medical evaluation. Chronic glomerulonephritis results in inflammation followed by progressive destruction of the glomeruli. So subclinical progression of the disease leads to hypertension, hematuria, which is blood in the urine, proteinuria, which is protein in the urine, oliguria, which is scanty urinary output, and then edema. Immune mechanisms suspected to be a major cause of chronic glomerulonephritis. Primary renal disorders and multi-system diseases are other causes. The treatment, control edema, treat the hypertension, and prevent congestive heart failure and uremia. So the congestive heart failure could occur from the severe edema and fluid retention. Uremia is the collection of an accumulation of urea, which basically when the body's not cleaning out the blood, when the kidneys aren't cleaning out the blood, we get toxic levels of urea and other waste products. So this is showing chronic glomerulonephritis. You can see the inflammation and the destruction of the kidneys. Dialysis. Dialysis filters out unwanted elements from the blood by diffusion across a semi-permeable membrane. There are different types of dialysis. There's hemodialysis and there's peritoneal dialysis. So we use dialysis when the kidneys are not functioning properly. So now the filtering mechanism of the kidney and is not working, so we have to use an outside source. So the proper fluid, electrolyte, and acid-base balances are maintained in the body. And so that's why we would have to use an outside form of dialysis, either hemo or peritoneal. So hemodialysis removes impurities or waste from the patient's blood by using an artificial type kidney. So what happens with hemodialysis is the blood moves out of the body, goes through a machine, is cleaned, and then returned to the body. Peritoneal dialysis uses a diacylate solution and the peritoneal membrane to filter out harmful toxins and excess fluid. So what happens is a diacylate solution is infused into the abdomen, and then the peritoneal membrane actually works as the filter, and then the dirty diacylate solution is then drained, and clean diacylate is then put back into the body. So here's hemodialysis. And so what we have here is the blood is removed. There's a fistula, which is actually where an artery and a vein in the forearm are connected to give a large port size here in the arm. So fistula looks like a big lump in the arm because the arterial side pressure causes the vein to actually dilate. Because the venous side, of course, the vein has thinner walls, so it gets larger, which gives a nice port, so they can put the needle in the arm, the catheter. So The fistula would be here in the arm. Blood is removed, goes through the machine, gets cleaned through the semipermeable membrane, and then is returned to the body. So that's where people go to dialysis centers. They may go 2 to 3 times a week. They're there for maybe 2 to 4 hours at a time. Peritoneal dialysis, here we have the clean dialysate, which is put into the peritoneal cavity, and the peritoneal membrane works as the filter. After several hours, the dirty fluid is then removed, and with all the waste products, and then clean dialysate solution would be infused again into the peritoneal cavity. So dialysis and kidney transplantation are the only two real options. Well, there is a third option if somebody has kidney failure. So if the kidneys are not functioning, if there's irreversible kidney failure or damage, then the person is either going to need dialysis, a kidney transplant, or they will die. So that's the third option. So surgical replacement of the kidney of a donor kidney into a patient with irreversible kidney failure. So immunosuppressive agents are going to be used to prevent rejection. So even though the person is getting a new kidney, which is beneficial to life, the body will reject it because it sees it as foreign. So they need to be on anti-rejection, anti-suppressive drugs for the rest of their life. And then there has to be a thorough evaluation of the donor and recipient to find good human leukocyte antigen match, which offers the best chance of good prognosis. So when someone gets, oops, sorry, didn't mean to click that. When someone receives a kidney transplant, they're not going to remove the bad kidneys. So the bad kidneys or the non-functional kidneys in the recipient stay there. They're not going to do anything. It's actually very, very difficult surgery to remove the kidneys because they're really plastered in there to the posterior abdominal wall. So the person who receives the donor kidney now actually has 3 kidneys. So they have 2 non-functional kidneys and then the donor kidney. So the person, if they're living, that donates the kidney actually has a very, very complicated surgery to remove that functional kidney to donate it. Okay. So, and then the person who donates the kidney, if it's not a cadaver, if it's a living donor, they will live the rest of their life with 1 functioning kidney. And you can live a normal, healthy life with 1 kidney. They're just going to have to be really careful that they don't damage that kidney. And then the recipient can live a normal, healthy life with that 1 kidney. They just have to stay on medication so that their body doesn't reject it. All right, nephrotic syndrome or nephrosis, either term is correct. This is a group of symptoms, sometimes referred as protein-losing kidneys. Now, protein is large and should not be filtered across in the nephron from the glomerulus to Bowman's capsule. So patient loses excessive amounts of protein, mainly albumin in the urine, so they have proteinuria. Glomerular filtration becomes diminished and water and sodium are retained. So caused by increased permeability of the glomerulus, indicating renal damage. So if somebody is spilling protein from the kidneys and in the urine, that's that's very bad, and that means that something is wrong with the filter. So treatment begins by addressing the underlying cause of the nephrotic syndrome. So again, treatment would be determined by the etiology. Acute renal failure. Symptoms include oliguria, which again means scant urine output, gastrointestinal disturbances, nausea, vomiting. They may have diarrhea, anorexia, headache, drowsiness, and other alterations in consciousness. The causes of acute renal failure are classified as those that result in diminished blood flow to the kidney. So it could be that the person is hemorrhaging, have some kind of blood loss, involves intrarenal damage or disease, and mechanical obstruction of renal flow can cause acute renal failure. And so when someone's blood pressure, let's say they go into shock and they're hypotensive, the loss of blood pressure can cause acute renal failure. So restoring blood flow to the kidney is essential to restore renal function. So determining the cause of acute renal failure is crucial in the course of medical management. The ultimate goal is to reverse the decreased renal perfusion. Fluid intake and output are balanced to prevent overload. Drug therapy may include antihypertensive, diuretics, and anti-infective agents, depending on if that's the cause. With prompt treatment, acute renal failure can be reversed. Chronic renal failure, on the other hand, cannot. So systemic effects eventually can be manifested into any and all body systems. Patient feels tired, weak. Retention of water causes hypertension and edema. Blood studies will show elevated blood urea nitrogen. So that means that there are waste products being retained. Serum creatinine and potassium levels are also elevated. And then the underlying cause must be treated. So dialysis and kidney transplant may prolong life. Diet modifications, monitored fluids, and drug therapy are used. Pyelonephritis. So pyelonephritis usually is caused by an infection, pregnancy, or renal calculi, and calculi are stones. So pus collects in the renal pelvis with the formation of abscesses. The patient experiences rapid onset of fever, chills, nausea, vomiting, and flank pain. And this is usually from bacteria that ascend from the lower urinary tract. So that means ascend means they go up. So they go from the urethra or the bladder, they ascend up the ureters and into the kidneys, which causes pyelonephritis. So catheterization or endoscopic examinations can directly introduce organisms into the bladder. So it could be from non-sterile technique, from catheterization or endoscopic examination, or an untreated bladder or urethral infection. So here's some causes of the infection. And so they're just showing residual urine, obstruction, so all sorts of different things. Stasis urine from immobility. So treatment of choice consists of intravenous or oral antibiotics, usually penicillin, fluoroquinolones, or cephalosporins, which are all different types of antibiotics. And the treatment will be 10 to 14 days. And then prevention includes drinking lots and lots of water, and we advise females to avoid or urinate after engaging in sexual intercourse to decrease the risk of developing urinary tract infections. Hydronephrosis. So here we know with hydro that involves water or fluid. So usually a chronic condition with destruction of the kidney without pain or symptoms. It's caused by buildup of pressure in the kidneys from an obstruction. So there's an obstruction in the ureter and it causes backflow into the kidney. So treatment depends on the underlying cause of the obstruction and duration of the obstruction. So it could be from a kidney stone that's lodged in the ureter, or some type of twisting or torsion of the ureter, which causes backflow into the kidney. So here we can see renal calculi and hydronephrosis. So there was a stone which caused dilation of this renal pelvis, and then caused destruction of the kidney. So here we have renal calculi, a stone in the ureter, and here's another one here, and then here's some here in the renal pelvis, and then in the calyces, and then here's hydronephrosis. So it's causing dilation and swelling, and which ultimately causes destruction of the nephrons and can cause kidney failure. So once the obstruction has been resolved, the kidney may return to normal function. Preventing kidney stones and the subsequent obstruction of the urine flow may also help prevent hydronephrosis, and they encourage patients to follow a suggested diet and fluid regimen to prevent kidney stones. Renal calculi. All right, so renal calculi or renal stones. So kidney stones can be solitary or multiple and vary in size. They can be really small, like grains of sand, or they can be large, that they actually cause an obstruction. So the patient's symptoms depend on the degree of obstruction. If they're very small, like sand, they may pass without any symptoms at all. So we would actually have to strain the urine in order to actually identify them. But if they're large and they get stuck in the renal pelvis or the ureters, then they would cause a renal colic or symptoms. So the renal colic would be the pain. There would be urinary urgency and other urinary symptoms, usually abdominal pain, back pain, which is very severe. It's actually compared to childbirth. Nausea, vomiting, hematuria, fever, chills, and abdominal distension. The patient experiences pain from a kidney stone and is considered an emergency situation. So when someone has a kidney stone, they need to go to the emergency room and be treated. The cause of calculi is unknown, although it could be hereditary. For the development could be hereditary. The goal of medical care is to remove the calculi, treat the pain, and if there's an infection, and resolve causative factors. Infectious cystitis and urethritis. So cystitis would be involving the bladder, and urethritis would be involving the urethra. So inflammation and infection cause urinary urgency, frequency, and dysuria. So the person has to go to the bathroom. They need to urinate frequently, and when they need to go, they have to go right away, and they may have pain or burning or difficulty with urination, and even urinary incontinence, which means they're spilling urine. Usual cause of cystitis and urethritis is an ascending bacterial invasion of the urinary tract. So treatment consists of organism-specific antibiotics or urinary antiseptic therapy. Most lower urinary tract infections respond well to drug therapy. If not treated, then we know pyelonephritis could develop if the infection ascends or goes up into the kidneys. Here's acute cystitis. So this is the bladder, which is severely inflamed. Diabetic nephropathy. So this is clinical manifestations include urinary retention, hypertension, nausea, and protein in the urine. Diabetic glomerular sclerosis is a complication of diabetes mellitus. So untreated diabetes mellitus or poorly treated diabetes, lesions of the glomeruli eventually cause the filtration rate to decrease. So the filtration and urine formation, there's going to be spilling of protein, possibly red blood cells, and then there's going to be large volumes, of course, of glucose in the urine as well from the untreated or poorly treated diabetes. So treatment plan must be individualized. Drug intervention includes ACE inhibitors for blood pressure control, because keep in mind, if the kidneys aren't working well, then it can cause problems with blood pressure and vice versa. If there's problems with blood pressure, it can cause kidney problems. So we have to control blood pressure and prolong proper kidney function as well, if it's possible. Polycystic kidney disease. So this is where there's many cysts in the kidney. So condition is bilateral, affects both kidneys, with cysts that form from dilated nephrons and collecting ducts. So the kidneys become grossly enlarged with compression of surrounding tissue. This leads to impaired renal function and then eventually renal failure. So the patient experiences lumbar pain, so low back pain, abdominal pain and tenderness, hematuria, and then systemic hypertension. So polycystic kidney disease is an inherited condition. So here you can see adult polycystic kidney disease. When we take an x-ray of the kidneys, what they see is this bumpy, rather than the kidneys should be smooth, but they'll see bumps and they can see the outlines of the cyst. So for this person with polycystic kidney disease, they will do radiographic films, abdominal CAT scans, abdominal MRIs, and IVPs show the enlarged, deformed kidneys. So treatment of this, it's going to cause end-stage renal disease, consists of dialysis, and then eventually, hopefully, a kidney transplant and surgery. There's no prevention of the inherited polycystic kidney disease. So this person with polycystic kidney disease is either going to need dialysis, a kidney transplant, or they would die. Neurogenic bladder. So this is an insult to the brain, spinal cord, or the nerve supplying the lower urinary tract, and may result in inability to empty the bladder of urine or to maintain urinary continence. Treatment is directed towards prevention of urinary tract infections and attempts to restore some normalcy in function. So catheterization, whether intermittent or indwelling. So intermittent means they would straight cath themselves. They would put a short catheter into the bladder via the urethra, drain urine, and then remove the catheter. Indwelling means that they would have a catheter put in and it stays in to drain the urine into a bag. So they would need catheterization to help the patient maintain an acceptable quality of life. Symptoms of neurogenic bladder. So symptoms and signs may vary. The patient with sensory-related problems experience hesitancy and decreased volume in urinary stream. Others may experience urinary retention resulting from decreased or absent stimuli. So what that means is they retain urine because they don't have a sense that they need to go. So their bladder would just fill, but they wouldn't have that sensation of I need to urinate. If the condition results in motor paralysis, the patient has the sensation of a full bladder but is unable to actually initiate the stream of urine to empty the bladder. So that's motor paralysis. So they have sensation, but they don't have the motor movement. They're not able to actually go. So patient with uninhibited neurogenic bladder is not able to control the voiding pattern and is persistently incontinent. So they would need to use something like a diaper or some kind of absorbent pad because they would just spill urine. Urinary catheterization involves the insertion of a catheter into the urinary bladder through the urethra for the withdrawal of urine and also for irrigation of the bladder with therapeutic solutions. So we're either draining urine or we may be instilling something into the bladder. So this, when we do urinary catheterization, it needs to have strict sterile technique to prevent introduction of pathogenic organisms into the urethra and the bladder. So here's urinary catheterization. Here is indwelling female catheter. So we insert the catheter, which the urethra is very short for females, into the bladder. We inflate a balloon so that it stays in there and indwelling, and then the urine drains out. For male catheterization, because the male urethra is much longer, it has to go through the penis, and then there would be inflation of the indwelling balloon, and then we would drain the urine. Stress incontinence is a symptom, a sign. There's symptom and a sign and a diagnosis. So stress incontinence can be seem like an emergency for an individual experiencing it, but it's actually a weakening of the pelvic floor muscles and the urethral structures. This causes embarrassing disorders. So some of the things that we would see here is spilling of urine. So women, this mainly happens in women. It's related to hormonal changes of aging and menopause, and it makes the condition which makes it more common in older women. This can happen in women actually in younger women after childbirth as well. And so women, when they cough, sneeze, laugh, they may leak urine. So it's much more common in women than men. So treatment, exercises to strengthen the pelvic floor muscles, estrogen replacement, drug therapy, surgical repair, and collagen injections can be helpful. So urinary incontinence it can be partial or total loss of voluntary control of the bladder with inability to retain urine. So the person drains or leaks urine. It sometimes is experienced temporarily after stretching of the muscles during childbirth, which can be, from a lot of pressure on the bladder, inflammation to the urethra. Neurologic damage may result in permanent incontinence, and treatment is according to the degree, the type, and the cause. So treatment, again, would depend upon the etiology. Overactive bladder. So this is uncontrollable urge can result in urinary incontinence with the accidental loss or leakage of small amounts of urine. You see a lot of commercials now about overactive bladder. They say, gotta go all the time. So the person with overactive bladder, symptoms can never be sure when they will occur. So they are always worried about being close to a bathroom. Overactive bladder muscles transmit false signals to the brain, therefore before the bladder is actually full. So drug therapy involves 3 different types of medications, which are discussed in your book. Renal cell carcinoma, RCC, description, the most common form of renal cancer. So renal cell carcinoma is the most common form of renal cancer, and that would be in adults. The other types are Wilms, so it's pronounced with a V, not with a W. Wilms tumor, which is a congenital tumor seen in children, and it's a cancer of the renal pelvis. The classic triad of symptoms of renal cell carcinoma is hematuria, abdominal mass, and flank pain. So renal cell carcinoma, around 95% of cases are sporadic, but some familial forms are known, so hereditary. The most common is a component of the von Hippel-Lindau syndrome. Risk factors for renal cell carcinoma include smoking, obesity, and hypertension, and also exposure to chemicals. So there are some chemicals that increase the risk of developing renal cell carcinoma. Things like exposure to fuels and other types of chemicals. Treatment of choice of renal cell carcinoma is surgical removal. Metastatic renal cell carcinoma is usually resistant to surgical cure and to radiation and chemotherapy, so the prognosis would not be good. Here we can see a renal cell tumor, so this is definitely not a healthy kidney. Bladder tumors can develop at any site of the urothelium-lined urinary tract. So most common symptom is gross, intermittent, painless hematuria. So if somebody has blood in the urine with no other symptoms, what we need to do is first rule out bladder cancer, so bladder tumors. So this would be someone with blood in the urine. They're not having burning or frequency or urgency, so it's painless and there's no other symptoms. So environmental exposures are thought to account for most cases of bladder cancer because the surface epithelium is exposed to potential carcinogens. So environmental exposures to chemicals, what happens is they go through the bladder, and the endothelium and the epithelium are actually exposed to these carcinogens through passing through the epithelial layers. So this is just showing you a Wilms tumor. This is renal cell carcinoma, and these are tumors of the bladder and the other layers of the epithelium and endothelium. So here's bladder cancer, and this is it at the microscopic level. All right, bladder tumors. Standard initial treatment is surgical removal of the tumor. For non-invasive carcinoma, they will do what they call the TURBT follow-up. The TURBT follow-up includes urine cystology and cystoscopy at 3 to 6 month intervals for 3 to 5 years. A cystectomy is indicated for patients with many reoccurrences and resistance to the intravesicular therapy, so that would be removal. An invasive carcinoma is treated with either radical cystectomy or partial cystectomy, which is entire removal of the bladder, or partial removal, followed by chemoradiotherapy. And that is it for Chapter 11. I hope this was helpful.